Thank you, everybody, and it's a pleasure to be here. Especially thank you to Kasidin for the invitation to this very beautiful country and a very well-organized conference. So we'll start with the history of minimally invasive surgery. Hippocrates himself first described insertion of instruments through an orifice to visualize the internal anatomy. This was way back more than 2,000 years ago. And the Arabian physician Abu Qasim used reflected light to examine the cervix. And Thomas Edison, of course, invented the light bulb in 1879. And several years later, endoscopy was well established in evaluating natural orifices, cystoscopy, rectoscopy, gastroscopy, and laryngoscopy. And the first diagnostic endoscopic procedure was performed through the vagina to inspect the pelvis. This is more than 100 years ago. And Jacobius reported 115 laparoscopies and thoracoscopies and coined the term laparoscopy, which comes from Greek lepra, which flank, and scopio, to see, to see the side. And the advent of CO2, pneumoperitoneum in 1924, this significantly reduced the risk of intra-abdominal explosions. However, the next 50 years, there was hardly any progress until the first laparoscopic appendicectomy in 1982, and the first laparoscopic cholecystectomy in 1985. And the first laparoscopic assisted colectomy was performed in 1991, and this was definitely considerably more difficult than appendicectomy and a cholecystectomy because it involves more than one quadrant, mobilization of the bowel, anastomosis, and specimen retrieval. Now, we all know that laparoscopy is now proven to be safe. Several landmark trials, the COST study, COLOR study, classic trials, all have proven laparoscopy to be safe. However, MIS colorectal surgery, despite having less pain, faster recovery, also has a steep learning curve of 20 to 50 laparoscopic cases, not just for the surgeon, but also the assistant and the cameraman. Now here you can see a classic open surgery, midline incision, and in the middle you see laparoscopic surgery with a mini laparotomy, right, where you extract the specimen through extended midline incision. The other common way of extracting the specimen would be a transverse phalansteal incision. Here's a classic case of example of that. And this is some examples of natural orifice specimen extraction. This is for right hemicolectomy and a sigmoid colectomy. And here you have one for low anterior resection. You can see it's quite different. Now we're all recovering from Olympic fever just a couple of weeks ago. So this, interestingly, is a picture from the 1900 Summer Olympics in Paris. And 24 years after that, a Summer Olympics in Paris again for a different female tennis player. And this is this year in Paris, the winner of this year's Female Tennis Open Olympics. So this is a bit, you see the difference between 1900 and 1924. It's quite different, right? The style, the fashion, quite different. And this is quite similar to how open surgery is with laparoscopic surgery. The difference is quite dramatic. But if you see the difference between 1924 and 2024, there's not much difference, right? You think, oh, it's just a bit smaller. But you know how much effort and nutrition, training, psychological counseling, coaching goes into the player of today and the player of yesterday. And if you pit this year's winner with the winner of 1924, you see the difference. Of course, tennis is popular in Thailand as well. I'd like to congratulate the tennis from Thailand of winning Thailand's gold medal. So natural orifice specimen extraction is a logical progression in the evolution of MIS surgery. It was first employed by urologists and gynecologists. Interestingly enough, the first transvaginal extraction was performed in the same year as the first laparoscopic colectomy in 1991. Okay, but since then, it's not really performed until almost 5 or 10 years ago. And the first transanal specimen retrieval was performed in 1993. And specimen retrieval via the anus or the vagina replaces conventional specimen extraction from a midline or a phalansteal incision. Here there are several recent meta-analyses. And all these meta-analyses demonstrates the benefit of nose in terms of the overall complications, incision-related complications like infection, wound herniation, intraoperative blood loss, postoperative pain, and return of GI function as well as length of stay. And all these meta-analyses showed no significant differences in terms of local and distant recurrences, and 3 and 5 year disease-free survival as well as overall survival. And I would say it is another step towards the holy grail of scarless surgery. This is some of our evidence. This is very early on in our experience. From February to October 2021, we used both transanal and transvaginal nose, and we propensely matched this cohort to patients with a conventional extraction based on age, gender, type of resection, and TNM stage to a non-nose cohort. And here you can see the differences in terms of time to bowel movement, length of stay, post-op day 1, day 2, pain, as well as morphine use. And all of them are significantly different in the nose group, in fact, improved. And there's no difference in terms of operative duration. In fact, the nose group was slightly faster than the non-nose group. Now, why is nose not performed more often? Now, I feel there are 3 main reasons. Now, the first is concern about the risks of doing nose, right? Now, what are the risks? Number 1, bacterial contamination. Because we're trying to extract through an orifice, you can potentially spill luminal content. This is the same as intracorporeal anastomosis. The second is tumor seeding. And the third, especially for vaginal extraction, is sexual dysfunction and dyspareunia. Now, we have done a meta-analysis comparing transanal specimen extraction with transvaginal specimen extraction, including 13 studies, 2 RCTs, 11 cohort studies. And we found that transvaginal specimen extraction had significantly less post-operative day 1 pain, shorter length of stay, and better cosmetic outcomes. Of course, this is already proven from multiple meta-analyses from before. This is just to reinforce that. The time of operation was similar, but look closely into the complications. This table shows the overall post-operative morbidity. It favors transvaginal specimen extraction. This table looks at the wound-related morbidity. It favors transvaginal specimen extraction. And this table looks at the non-wound-related morbidity, and this favors transvaginal specimen extraction. Now, how about the sexual dysfunction and oncologic outcomes? This review shows there's no difference in sexual dysfunction scores or dyspareunia. In fact, one of the studies by Gongodak shows a higher incidence of dyspareunia with the transabdominal specimen extraction compared to transvaginal at 3 months. And the authors postulate that this sexual function was worsened by a physical perception of the scar. So there's also no difference in lymph node harvest 2-year DFS as well as 3-year DFS. And very interestingly, none of these 13 studies reported any instances of port site, pelvic, or vaginal disease recurrence, contrary to the prevailing mentality. So there's no evidence to show that there is increased risk with nose. And number 2, we are not sure who to select for nose, just like the Australians. So, of course, this paper is widely cited. The International Consensus on Natural Orifice Specimen Extraction for Colon Cancer. There you have several criteria. They go by size, less than 3 cm for transanal noses and 3 to 5 cm for transvaginal noses. They select T2 or T3 most appropriately. There's also a BMI cutoff. And of course, no anal stenosis, anal dysfunction for transanal noses. And young women who have not finished their family should not be considered for transvaginal noses. Now, however, this is a consensus. It's not really evidence-based, but more on that later. This is our own series and experience with transvaginal noses, and we find that the most important selection criteria is the overall specimen diameter, not just the tumor size, but the tumor and the mesentery, relative to the pelvic outlet and conduit diameter, which means the anus or the vagina, depending on the nose that you're selecting, is the most important consideration. And this oftentimes can only be detected intraoperatively because you can't tell the bulkiness, the size of the mesentery on the scan. And you also cannot tell the relative size difference between the specimen as well as the extraction site. Now, number 3, the perceived technical difficulties with natural orifice specimen extraction. That's the third problem. So how do we prepare the proximal bowel in left-sided resections, right? Of course, if we do conventional laparoscopic surgery, we make a small incision, we bring up the proximal bowel, and we just stitch the anvil on, right? That's how we do it. And this problem is not so easily done in natural orifice surgery. So as Professor Shen showed earlier, some people stitch the anvil on like this. So you apply a Prolene purse string, we put the anvil and you stitch it on. Secondly, we can also bring down the flexure and exteriorize the proximal bowel through the conduit of choice, be it the vagina or the anus. Here you can see a patient with the proximal bowel pulled out and the tumor still in situ. And we extract and we transact and anchor the anvil exteriorly. However, I've also innovated a technique to make things easier for everyone, and this involves using the ancillary trocar. I'm sure most of you don't know what that is, but it is the spike that comes along with the anvil, and this is sharp. It can be attached onto the anvil and poked through the anti-mesenteric surface of the proximal bowel, and the colon, the colostomy end is stapled off. This is a very quick way. It just uses one more linear stapler compared to conventional laparoscopy, but it's very fast and there's very minimal intracorporeal suturing required. Using this method from 10 patients in our series, they only stayed 1 day. So this also emphasizes the benefit of using natural orifice specimen extraction. And I call this technique the IAAT technique, intracorporeal anti-mesenteric ancillary trocar technique. Now, nose is not just limited to one type of resection, right? It can be done for any kind of colorectal surgery. And we have tried to demonstrate it for anterior resection, of course, even patients with high BMI, patients using a right hemicolectomy, patients doing a combined hemicolectomy as well as liver mets resection, and a splenic flexure colectomy or left hemicolectomy. And later on, during lunchtime, I will demonstrate how I did a nose technique for a total colectomy in a patient with a right-sided synchronous tumors. Now, some advanced applications of nose. Now, this is a series that we performed for natural orifice specimen extraction along with liver mets resection. So in this series, all the patients that we did recovered GI functions within 2 days, again, emphasizing the benefit of natural orifice specimen extraction. And the mean length of stay for these patients, who have extended long surgery, long resection, big surgery, was only 3 days. Again, showing the benefit of natural orifice extraction. This is early in our series. I won't talk too much about this, but essentially is using the vagina to do the full surgery, not just to extract. This is called V-nodes. I've done before, but this is the first case that we do intracorporeal anastomosis for right hemicolectomy using V-nodes. So this again, another step towards scalar surgery. Now, how about beginners? Because I'm showing all these advanced techniques. And I understand from Dr. Kasidin that many of you here are trainees or fellows. And how do we start doing natural orifice surgery? Right? We can't do liver mets for the start, right? We have to start somewhere a bit more simple. So, uncomplicated sigmoid volvulus actually we found to be ideal for transanal nose. And it's very good for beginners. Why? There's no intraluminal lesion. So there's no worry about not being able to remove the specimen. And normally for volvulus, we do close bowel dissection. There's no mesentery as well. So even if the mesentery is bulky, it doesn't matter. You're not taking it. And there's no risk of tumor seeding. And I say this because I don't believe there is. But if you do believe so, there isn't any for volvulus because it's a benign condition. Now I'll show one case report as well as the video for this patient. This is a 66-year-old female, ASA2, quite a skinny patient, and she has recurrent sigmoid volvulus requiring endoscopic decompression. So she was planned for laparoscopic sigmoid colectomy. I did the IAAT technique, which I'll show in the video, and transanal natural orifice specimen extraction. These are the ports that we used. So this is the video I have. So this is the very long sigmoid colon. We traced it from the DS junction to the RS junction. And you can see there's no adhesions that we need to break. And we do a close colonic dissection, starting from the middle of the sigmoid. And this is progressed proximally up to the descending sigmoid junction. So this part is quite easy. So it's important to dissect all the way to the DS junction so that all the redundant sigmoid is removed. That's the descending and that's the sigmoid. And following that, we occlude the proximal bowel with a silk tie. And then we progress the dissection distally to the rectal sigmoid junction, again with closed bowel dissection. We hitch the uterus anteriorly to the abdominal wall. And then again, like the proximal bowel, we occlude the distal bowel with a silk tie. Thereafter, the rectum is washed out to prevent the risk of luminal spillage, and the bowel is transected. That's the rectal stump. And we introduce an Alexis wound protector to the rectal stump. And this Alexis protector is tightened against the perineum to shorten the distance of the conduit, the length of the conduit, to make nose extraction easier. And we introduce the anvil, as I mentioned before, with the attached spike. And the proximal bowel is transected. You see the tie is to prevent spillage of the distal content of the sigmoid. And now this is the technique that I use for almost all my left-sided nose cases these days. I introduce the spike at the anti-mesenteric border. Make a small hole about 2 to 3 centimeters from the cut edge of the bowel. And this can be put in quite easily. And the colon end is stapled off using one additional linear reload. So there's no need to do very complicated stitching with the proline. And this is removed transanally. And this may or may not be essential, but I do it just to be safe. I don't want the spike to be slipping back into the bowel wall, into the bowel lumen, just a few throws of the proline. This can be detached quite easily as well, the ancillary trocar, and removed. Thereafter, we do the natural orifice extraction. So it's very satisfying to do this for a volvulus case because it's very, very smooth and easy. There you have it. And the Alexis protector is removed, and the rectal stump is closed. Now this can't be too bulky, if not you have no way to remove it. So you have to make it slim and move it to the 12 mm port. And thereafter I do a side-to-end anastomosis, and this is as usual. And I stitch the anterior staple line to be safe. These are the donuts. And that's the specimen. And you can see the excellent cosmetic outcome from the natural orifice surgery. So this was 2 hours, 20 minutes, minimal blood loss, and the patient was discharged on post-operative day 1. So again, emphasizing the benefit of natural orifice surgery. And there were no post-operative complications. Now, one last tip, how about failed nose? Now, one series showed a 1 in 4 failure rate of 67 patients, and I had 2 failed nose early on in my learning curve. For my transanal nose which failed, I converted to trans-abdominal extraction as usual, and I stapled the rectal stump. For the failed vaginal nose, all I had to do was to stitch the vagina and extract transabdominally. So it's not difficult if you fail the nose. Just remember, do not persist. If you persist, there will be specimen rupture, and then there will be recurrence in the pelvis. In conclusion, nose surgery is beneficial. Patient selection and intraoperative assessment is essential. It's more challenging versus conventional specimen extraction, but not difficult to do if you know the technique. And it must not compromise the principles of oncologic surgery. Sigmoid volvulus is also an ideal condition to start nose surgery for fellows and trainees. Thank you very much.
Thank you very much, Dr. Isaac. So, any question, please?
Thank you. From your meta-analysis, I didn't see the details of patient's age. I'm wondering if this technique is suitable for young age or just suitable for old age women. Thank you.
Yes, it's an excellent question because there's always this fear that doing it in young ladies or childbearing age when they want to deliver transvaginally, there'll be issues. But if you ask your gynecologist colleagues, they do transvaginal surgery all the time, even in young patients of childbearing age, sexually active patients. So actually, even though there's a theoretical risk of having this dyspareunia, it's being done in patients of childbearing age all the time. In this series, many of them excluded such patients, so all older. But in my experience and that of my ONG colleagues, OBGYN in my hospital, they do transvaginal surgery, even V-node surgery, for patients who are young.
Yeah, I'm waiting for your young age patients' conclusion. Thank you.
Thank you.
I have one question. Does any considering to you to not perform nose?
Yes, I think the main consideration is bulky tumor. Circumferential tumor and bigger tumor is not a contraindication, but only if they have very wide pelvic outlet as well as a very lax vagina. So it's relative. If the patient's tumor is too big, the mesentery is too bulky, I just do a trans-abdominal extraction. So that's the main contraindication for me.
No, thank you very much.
Any question to Dr. Isaac? Okay, so